Good evening. This is Dr. Eduardo de Marchena. I'm a professor of medicine and surgery at the University of Miami, and I'm the director of the structural heart disease training program here, and director of Miami Valves. Miami Valves is a conference that's been going on in one form or other for almost 20 years. It's last 6 years, it's dedicated specifically to structural heart disease, advances in valvular therapies. Unfortunately, because things in the world change so rapidly, we had to change the format. Normally we do this conference in January or February and in person, obviously, in Miami. But because of COVID, we had to reinvent ourselves, like all of us have had to reinvent our lives. And so we decided to do this instead as a tele-webinar that you all are participating in. This will give you a flavor of how we normally do these meetings. And we will be continuing with live meetings next year. There's a lot of people that have to be thanked for any of these programs, and a lot of people that participate in planning. Obviously, we want to thank all of the attendees that are joining us from throughout the world. Our fabulous faculty, and you'll get some of them today, and you'll see some of them in the subsequent nights. It's going to be 7 subsequent Wednesdays that you're going to be able to join us from 5 to 7 with different areas of interest. The first 4 will all be in structural heart disease. The 5th one will be in PCI, advanced PCI, then advanced electrophysiology, advanced heart failure care. And then there'll finally be a symposium on a Saturday, which will cover also circulatory mechanical support and heart transplant. We want to thank, obviously, my co-faculty, which are my colleagues in structural heart, Dr. Cohen, Alfonso, Dial, our cardiothoracic surgeons, which are fabulous, Dr. Lamelas, Abari, Gosisab, that help us in many of the structural cases, our fabulous UMH structural coordinator, Brenny Capote. The International Medicine Institute is second to none. They're awesome. Dr. Suresh Atapatu has always helps us tremendously with the organization and web design, so forth. Julissa Gutierrez is my right hand and has helped us all throughout this. Johanna Lucena has done most of our social media and many of our brochure planning. Jennifer Alvarez is doing our Zoom sessions. Marini Ikao does all our international research here, and he's helped us tremendously with the South American portion of this meeting. Carla Duarte is my fabulous clinical secretary that has made time for me to be able to put this on. And you all saw who Oriana Cerillo is, our wonderful UMIT helper to be able to do this conference. I want to thank our CVICU nurses, our surgical and floor clinical nurses that allow us to be able to take care of these complex patients with good success. Wonderful cardiac anesthesiologists and CRNAs. They also give us huge help with imaging during procedures. Our other imagers are echocardiographers, echocardiographic techs, and our wonderful radiologists and radiology techs that allow us to be able to plan for procedures beautifully, and our stress laboratory that helps us take care of this. This is an international meeting from multiple different organizations, and you'll be seeing cases from all these different places, and perhaps more by the time that we're done with our 8 weeks. This is the wonderful cardiac catheterization laboratory, I think second to none that we have. There's many more that have joined us since this picture, but we didn't have in the picture right now. But we want to thank all of them. And then our interventional fellows that work with us every day and night, and they've been very helpful, and they'll be doing predominantly the PCI symposium. And then a very special thanks to Sergio Perez, my 5th or 6th structural heart disease fellow, and my 2nd Eberhard Grube international structural heart disease fellow. He's been an incredible help in planning, and you'll see the fantastic work that he does in the laboratory. So let's go on to the fun. So this is an evening with Eberhard Grube and friends. We will be having first a lecture by Eberhard, and then following the lecture, we will have our panelists join us, and our panelists will then offer their insights and also share some of their cases. So Eberhard Grube almost needs no introduction for people that know structural heart disease. Besides from his many accomplishments in interventional cardiology, Eberhard has been one of the main visionaries and leaders in the development of transcatheter valve therapies, starting from its very origin in the early 2000s. He has investigated, proposed, modified techniques to improve the outcome of transcatheter valvular surgeries. He is an open-minded critical observer, impeccably honest investigator, and a powerful advocate for these modern techniques. Just to highlight a few of his awards, he received the prestigious Jeffrey Hartzler Master Clinical Operator Award from the TCT. He also received the Master of Master Awards from the Asian Pacific TCT. And in 2019, he got the Miami Valves Lifetime Achievement Award, which I think is the most important one, by the way. Whatever I call Eberhard, the first question I always ask him is, where are you? Since many times I've called him in the middle of the night, since he's teaching in Asia and Australia. Unfortunately, in this last year, he's been in social isolation in Germany, but somehow he's still been able to make a major impact in structural heart disease from his hiding place. Eberhard has taught most of the world how to perform, improve, and master transcatheter techniques. He's a professor of medicine and cardiology, chief of cardiac innovations at the University of Miami Bonn Hospital, consulting professor at Stanford University, a staff physician at the Instituto de Cardiologia Dante Pazzanese in Sao Paulo, Brazil. And he's going to be educating us today. By the way, the most important thing, I think he's also an incredible colleague and friend to almost everyone that he meets. He's going to be talking to us about a journey of transcatheter therapies moving forward. Eberhard.
So thank you very much, Eddie, for these very kind words. Let me just share the screen with you. Can you see it? Can you see my screen?
Yes, sir.
Okay, good. So thank you very much for your kind introduction, Eddie. It's really a great honor and a great pleasure to be there with all my friends. It's the next best to be in person, to see everyone in working clothes and scrubs, so we know the ones far away, like myself, is actually putting on a white skirt to give a good impression to all of you. When Eddie and I talked about the topic, he mentioned the transcatheter valve therapies, and obviously after embarking on TAVR, it's been my real hobby to go and move over to transcatheter mitral valve and transcatheter tricuspid valve. So I'm really happy that you gave me this topic beginning of this very, very important and very nice meeting. And looking at the beach and at the ocean, I wish I was there. But hopefully next year, or at a meeting in July, we're going to be hugging each other, probably at the site. So the title of my talk is The Journey of Transcatheter Valve Therapies Moving Forward. And I would like to start, obviously, with my the financial disclosures, which are summarized here. And, I would like to give a brief overview on interventional valve therapy. And in recent years, treatment options for valvular disease have grown tremendously and have truly been disruptive. This pace is likely to continue with future interventional therapies targeting aortic, mitral, and tricuspid valve diseases. But the very first transcatheter valve ever implanted was really a pulmonary valve. In the year 2000, Philipp Bonhoeffer and his colleagues implanted in the hospital Necker in Paris a novel transcatheter heart valve into a 12-year-old boy with pulmonary atresia and a stenotic RV2PA conduit. You see Philip and the valve on the right side. A brief history: the two leading valve platforms for treating dysfunctional RVO2 conduits, Melody and Sapien XT, launched major trials over a decade ago. And you can see here the year 2021 with important milestones: the approval of Melody in Europe, the United States, and the approval of Sapien XT in the United States. And last but not least, the approval of Harmony in the United States, the valve following Melody. The full 10-year follow-up from the Melody IDE trial presented in 2020 really marked the longest prospective follow-up available for any transcatheter valve to date. The results showed durable valve performance and favorable freedom from reintervention out to 1 year post-implant. Transcatheter pulmonary valve replacement was then actually the seed that sprouted all future transcatheter valve therapies. This is how it began. Moving on to TAVR and the major milestones. We all know these. Henning Ruud Andersen with his first porcine implant, a very, very nice Danish cardiologist, and of course, Alan Cribier, 2002 with the first human TAV implant. We all know those pictures on the left side with a glass of champagne with a patient that was very, very sick briefly before and after successful TAVR. He was able to take a toast with Alan. On the right side, the American Heart Association first human case description of this particular case. And this image, I know you remember all because it's so impressive. And words cannot describe when you look at the eyes of his team with Hélène and Christophe, first transcatheter aortic valve implant in April 2002, first ever. And you can see here the tension, the expectations, and maybe even the fear what's going to happen. When we started in 2004, we were much more relaxed, but believe me, it was the same tension when we disconnected the ECMO from the heart and we did the first cases. First clinical implant in summer 2004 with Jean-Claude, the 12th patient in TAVR history. I know you remember this from my talk, the first cases in 2004 with the first generation combined disease, and you can see a lot of aortic insufficiency. And even after today's standards, the results were really not bad given the first generation of the valve and the lack of experience. The first iterations of the current market leaders are shown here, and the several EF studies reported acceptable performance of both valves in inoperable patients. So these two valves received CE mark in 2002 to treat the underserved inoperable patient population in Europe. Obviously, the early skeptics came all about. On the left side, you can see a summary of what they said, but basically that summarizes this crazy and senseless project will fail and represents unacceptable and unethical experiments in humans. Well, TAVR was in retreat, no long-term data, cost benefit, stroke, pacemaker, urability, vascular complications. Suddenly, TAVR was under siege. But we said then, the warning came. Cardiologists may be closer than they appear, and that was actually the case. Let us remember Mark Zuckerberg in May 2017, Harvard commencement. It's good to be idealistic, but be prepared to be misunderstood. Anyone working on a greater vision will get called crazy, even if you end up right. He was so right, and it was so true for the TAVR story. So where are we today on our successful journey 2021? Let us remember, since 2007, more than 18,000 patients have been enrolled in FDA studies, including 14 randomized trials with multiple generations of 4 different TAVR systems. Altogether, more than 24 TAVR randomized trials have been performed. These trials, both for balloon expandable and self-expandable valves, demonstrated excellent safety and device success in extreme, high, and intermediate risk patients. Obviously, the next step was embarking into the low-risk population, and the good results, performing just as well as surgery, eventually led to the important expansion of TAVR into the low-risk patients in Europe and in the United States. A brief history, again, summarized here with yellow: first Edwards, 2002, first core valve, 2004, and then from 2011 on until today, the TAVR trials, randomized trials with various surgical risk scores. 2019, TAVR approved for low risk, and 2020, TAV and TAV approved for high risk patients. We all know this slide. Innovation takes place in TAVR, diverse landscape. You can see the current industry standards, valves with increased clinical use and increasing momentum. And you can also see some that left the marketplace. And on the right side, you see many more to come. Whether or not they would see the podium, we don't know yet. The good news, we all know, TAVR grows, surpasses surgery in the United States, as shown in red. Basically, the same is true in real world in Germany. Here, the line is in blue, TAVI versus surgery. There have been tremendous procedural advancements. Procedural refinements such as minimalist TAVR pathways, implant depth planning and execution of membranous septum measurement, cusp overlay technique, and Commissure Alignment for better coronary access are notable advancements to the field, as shown in the lower part. Basilica, valve fracturing, and protection devices of the brain are innovative augmentation to standard TAVR practice and are under ongoing evaluation, as we all know. So what remains to be done? Actually, we do have to close the knowledge gaps, the remaining knowledge gaps summarized on the left side. Most importantly, PCI post-TAVR, coronary access, and the lifetime management for younger patients. Which procedure comes first? Let's not forget, low risk is not younger age. But as we move into younger age, these questions, together with the ones above, are very, very important to be resolved. So what are we going to do with younger patients? Are we starting with surgery, TAVR? Or I would like to propose something which maybe is worthwhile being thought about. If we do find a device which does effective calcium scoring and opens up the calcified aortic valve and increases the opening area, maybe we can defer the TAVR or surgery, as shown here, from 50 to 60, 60 to 75, 75 to 85, and 85 above. Younger patients will likely require multiple treatments. And if we do have a successful device, such as the leaflets prove to last longer than balloon valvuloplasty, maybe we can avoid or defer an implant, because that's what we want, to defer these implants to an older age group. TAVR has proven to be safe and effective for severe aortic stenosis patients across all surgical risk categories. Heart teams now face new challenges of refining the procedure and perfecting outcomes for all TAVR candidates. Heart team plays a very fundamental role. Let's move on to transcatheter mitral valve repair and replacement. Management of mitral regurgitation, as we all know, is complex and often associated with multiple dysfunctions requiring a variety of interventions. Transcatheter approaches focus on leaflets, annulus, and chordae. The transcatheter mitral valve repair landscape is rapidly changing. However, a real milestone has only been achieved so far by the edge-to-edge technique of the mitral clip. We all know the mitral clip imitates Professor Alfieri, at least in part. Talking about the mitral clip milestones, Everest 1, Everest 2. Everest 2, as we all know, was the only randomized trial comparing the clip with surgery, and it showed no difference in mortality, but greater MR reduction in surgical patients and higher rates of reoperation in patients who received the clip. 2008, CE mark for primary and secondary MR. 2013, FDA approval for primary MR, and then came COAPT and MITRA-FR trials, and then consequently FDA approval for secondary MR. Percutaneous annuloplasty techniques is relatively new compared with its surgical counterpart, but significant progress has been made in recent years. Carillon, Accucinch, Cardioband, with their respective milestones. Carillon so far is the one that is most advanced with more than 1,300 implants, recently published some interesting meta-analysis data. Percutaneous coronary repair, early stage with most devices, either in preclinical development or limited human experience. NeoCord, on the left side, CE mark in 2012, experience in many patients, but really hasn't gotten any real traction as compared to surgery. Harpoon, Cordat, and Pipeline are in their early stages. So let me present a few innovative TMVR solutions, which is neither replacement nor repair. Maybe it is in the middle. Posterior leaflet enhancement and replacement is a new focus area for TMV repair of these and early in their experience. Polaris with their milestone, Sutra with their milestones, Half Moon that is cooperating with Medtronic, and AV with their respective milestones. Moving on to transcatheter mitral valve replacement, or TMVR. These devices have demonstrated favorable outcomes during initial studies, but overall development has been slower compared to TAVR systems due to complex anatomy and disease pathology. The TMV replacement field is dynamic, as we all know, with the introduction of new devices and discontinuation of others. Here, an overview from 2012 until 2019. Tendyne and Intrepid have the largest patient experience, as shown here, with 400 and 300 patients respectively, followed by Tiara and Sapien at 3, and then the remaining that are only enrolling a few patients. Basically, the clinical programs are summarized here. Tendyne received CE mark in January 20 and is the only TMV replacement device to gain regulatory approval worldwide. What's next? Replacement in MAC patients, both for Intrepid in the Apollo trial, Tendyne in the Summit trial, and Sapien M3 in the mitral trial. The reason the MAC patients have been excluded in these previous mentioned trials. And lastly, but importantly, transcatheter tricuspid valve, repair and replacement. We all know the tricuspid valve is no longer the forgotten valve. Tricuspid regurgitation has historically been overlooked. Interest in developing transcatheter devices as a less invasive alternative to surgery has gained momentum in recent years. Targets of interventions are direct suture annuloplasty, direct ring annuloplasty, coaptation enhancement, valve replacement, and last but not least, ectopic valve implantation, trick valve, and Tricento. Transcatheter TR treatment are early in their development and data is limited. The largest data set comes from the multi-center international TRIVALVE registry. Results of these 313 matched pairs showed that transcatheter intervention of TR was associated with improved clinical outcomes compared to conservative medical therapy. And MitraClip was the one that has been most commonly used device in this registry, as shown here in blue, MitraClip being used in 66% of the cases. The off-label use of the real-world TV clipping is summarized here. 249 patients, an average of 2 clips are needed. For the most part, anteroceptor leaflets in 65%, and together with tricuspid in 52%, the mitral regurgitation has been treated also. And you can see here both the reduction of MR and the New York Heart Association classification improved by this technique. Cardioband and Pascal are the only devices to receive CE mark for the treatment of TR. Both EFS studies show reduction and favorable safety profiles at 30 days. On the left side, Cardioband, and on the right side, Pascal. So finally, then, my last slide, what are the real milestones? The broad landscape of transcatheter heart valves began over 2 decades ago with pulmonary valve implant in a pediatric patients with congenital heart disease. TAVR therapies have seen tremendous growth and success in treating patients with severe aortic stenosis. With more than 18,000 patients, including in more than 18 randomized controlled trials across the surgical risk spectrum, TAVR established its position as first-line therapy in the patient group of aortic stenosis patients. Recent advancements in the field are focusing now on procedural refinements and patient selection. Another milestone was certainly the COAPT study with the mitral clip. For the first time, a device treatment proved to have a mortality benefit together with other positive endpoints over conventional therapy in the large group of patients with secondary mitral insufficiency. And finally, transcatheter therapies for mitral and tricuspid valves are a new and exciting field within structural heart innovation. These therapies have the potential to address great unmet clinical need in patients who are ineligible for surgical interventions. Further studies are needed to address concerns about safety, residual MR or TR, future device interventions, predictability of results, and of course, anatomical suitability. With that, dear Eddie, I would like to conclude. Thank you very much all for your attention, and I'm very happy that I can join this wonderful meeting. Thank you so much. You're muted.
Okay.
Now we hear
I
you.
said a very, very exciting journey that I know you were in throughout the very beginning, and you've been able to share insight all the way through, which is wonderful. So I'm going to go ahead and introduce my panel, and then we'll take a couple of questions, and then we'll start with the cases for this evening. So I don't think the Mauricio Cohen has been able to join us yet because he's stuck with a patient, but he will be joining us soon.
I'm here, Eddie. I'm here.
Okay, great.
I'm in the car. I'm going to my place, and I'll have a more stable place in the car.
Okay.
And I see Antonio Dagger is also joining. I see him.
Antonio's there, huh?
Yeah. Hi, Antonio.
Hi. Okay. So Antonio Dagger is a longtime colleague of mine. We actually trained together, and he's one of the biggest operators in Latin America. The Carlos Alfonso is another colleague of mine. He's the director of the fellowship program at the University of Miami, and also the director of our advanced coronary and CTO interventions program. He's a great structuralist. Fabio De Brito, many of you know. Fabio is becoming one of the leading interventional structural cardiologists in Latin America. He's the director of structural heart interventions at the Heart Institute in Sao Paulo Medical School in Sao Paulo, Brazil. Pablo Rengifo Moreno was the first structural interventional fellow at our program, and he's now an assistant professor in Florida State University. He's an interventional structural expert in Tallahassee, Florida. Felipe Albuquerque was also a former structural fellow. Now He's a structural heart specialist at Holy Cross Hospital in Fort Lauderdale. Joao Bragiroli, also a former structural fellow, is the director of the coronary care unit at Jackson Memorial Hospital. He's an expert in interventional cardiology and structural heart disease. Sergio Perez is my current fellow. You'll be seeing him a lot, and he'll be showing our first cases. He's a Harrington graduate, Harrington Fellow graduate, just like Antonio Dagger. It was one of the scholars from Latin America that joined and went through our entire program. Hector Rivera is going to be one of our future interventional fellows, and hopefully structural fellow in the future. He's going to be helping us with the question and answer periods from different participants. And so that's my panel. And first I'll open up the program for any questions to Dr. Grube. So Eberhard, when do you think that we will be doing transcatheter mitral valve replacement in the United States at the pace of the current trials right now?
I think it's going to last a while. We all know that. The journey has been quite long. Started in 2010, 11, depending on when you define the start. But it has been moving slowly, but continuously. Still many patients are excluded for various exclusion criteria. So before it becomes a mainstream interventional therapy, I think it will still last a while. Whether it's going to be, I think it's going to be a few years yet, given today's pace, even though we make progress, but the pace is much slower. We have to deal with many more issues as compared to the aortic valve. And Eddie, it is really important that we don't forget, as important as the progress is in interventional cardiology, as ambitious we all are to move the field. You remember we started out with the aortic valve saying, if the results are the same as surgery, as effective and as safe, then the less invasive techniques will reign supreme. This was our goal. And, you know, we haven't been there yet with mitral valve. It might be different with the tricuspid, but with the mitral valve, I think both on replacement and repair, we're not there yet, and it will last a while. But we're making progress. And certainly United States is, further off than the rest of the world, particularly, unfortunately, Europe.
Yeah, very good. I don't think there's any other questions right now. So is there any questions, Hector, from the audience?
No, sir, not at the moment. I do want to remind the audience you can use the Q&A to put in any questions, and we'll try to answer these as swiftly as possible.
Wonderful. So we're going to go ahead and start with our first case. So Sergio Perez is going to be doing the first case. So Sergio, can you share your screen?
Okay, good evening, everyone. I wanted to take this opportunity to thank Dr. Grube and Dr. Marchena mainly for everything they've done and they continue doing for this fellowship, and extend this appreciation to all the faculty and staff that I work with during this year, Dr. Alfonso, Dr. Cohen, and the remaining of the staff. Clearly, I wouldn't be able to be here completing this training without them. So thank you, everyone. I have no disclosures. So this first case of the night is the case of an 88-year-old man. He's a golfer. He was recently playing slightly above the par, the whole 18 holes. He's also a designer of golf courses who comes in with class 3 symptoms of exertional dyspnea. He has medical history of coronary disease, and he had a CABG in 1995. And then he also had abdominal aortic aneurysm for which he underwent an endovascular repair with bifurcating iliac stents in 2016. He had history of cardiomyopathy. However, his LV function recovered after placement of biventricular pacemaker a couple of years ago. So up until a few months ago, he was playing golf clearly, wearing face mask and safe distance from the caddy. However, now he's not able to play golf because his symptoms had got much worse. His physical exam discloses an AS murmur. The presence of severe ES is confirmed by echocardiography with high velocities and high gradients. And you can see that he has a biventricular pacemaker. So he was admitted at an outside hospital in which he was actually turned down for both surgical valve replacement because of redo and age and transcatheter valve replacement because they felt that transfemoral access might be challenging in the presence of the aortic and iliac stent graft. So he comes referred to us for a second opinion. This is his angiogram. You can see the native coronaries on the left. He has diffuse severe disease of the right coronary artery. In the middle of the screen, he has a prior stent in the left main into the circumflex that is patent, but not significant obstructive disease of the circumflex. However, a totally occluded LED. And same thing you can see on the right. And these are he has a patent vein graft, both to the distal right coronary artery and to a diagonal branch. And he has a patent lima to the LED. So he's fully revascularized at the time. So these are just some images of his CT scan. And I wanted to show the calcium distribution and the amount of calcification, both at the leaflets, but also at the sub and supraannular level. And you can see the aorta. The angle was deemed to be favorable on CT scan, an angle of approximately 40 to 45 degrees. And in the middle of the screen, you can see a couple of CT volume rendered reconstructions on the aorta. So with the limited information that I've shown thus far, I know it's not complete. We haven't talked about sizing, but with the limited information that I've found thus far, I don't know if anybody inclines toward one specific type of valve or with the other of the platforms that we have available.
Eberhard, anything in this case would make you want to lean towards one or the other of the conventionally available valves in the US?
Well, first of all, Sergio, it's a real pleasure to get to know you and see you, even though by Zoom, but hopefully we will see each other during the next months. Pleasure to have met you. Well, I mean, there's always the same question. You see a lot of calcifications here, possibly, yeah, there you go, extending into the septal curtain. And whenever you see calcium, if you decide to do a THV, then I would probably, due to the peripheral disease, I would, for two reasons here, probably use a device that has the lowest French size to get through the stents. And basically also due to the heavy calcifications that you can see there extending down, I would be probably leaning towards a self-expanding valve. In this case, probably an Evolute, and go ahead with that one. Obviously, you can do the same with a Sapien, but as we all know, with the balloon expandable and a lot of calcium, you just have to be very careful that you don't crack the calcium. And annulus rupture is an issue, potentially an issue, and obviously also the peripheral access with the peripheral disease. Granted, you can go subclavian with both, but I would probably go transfemoral and go with an Evolute Pro.
Anybody else in the panel? Felipe, which would you pick here? Somehow I don't hear you.
He's muted.
I don't know.
Yeah, I share the same opinion too. With the degree of LVOT calcification, extension, and I think self-expanding, it's safer for this patient.
Fabio?
Yeah, just to remember that the 34 doesn't have the Pro, so it would be the Evolute R, and maybe it would be nicer because of the it's also 16 French, the 34, and not larger than use it to be.
But he's size for 29, right?
We're gonna go into sizing in 1 second, but we actually felt the same that what all of you mentioned. We felt that because of the degree of subannular calcification, a self-expandable valve would provide the best results with the least amount of risk of LVOT rupture. So now going into sizing, we based on a perimeter-derived diameter, this size for a 34 millimeter Evolut Pro Plus. Sinuses were not effaced, significant room of the sinuses. And this, we haven't gone into the peripheral axis, but this is the reconstructions of both iliacs. And we felt that overall, there was good luminal diameter on both sides to allow passage of a 16 French or even larger, because as you will see in 1 second, we actually decided to use a Gore sheet, a 20 French sheet.
Let me just make a point here that this patient had actually been turned down at another institution because of the femoral approach. And we've had tremendous experience and also good results with going through stent grafts without major problems. We usually wait till they're at least 6 weeks old, but you know, the good thing is that you know exactly the lumen of these grafts, and it's big, and they also conform pretty well to the stiff sheaths as you advance them forward.
Eddie, this is Mauricio here.
Yes.
So Sergio, go back to the previous slide where you show the annulus. So the other thing that you have to look in here is that you don't have protruding. I mean, even though there's significant calcification around the annulus, you don't see much protruding, like you don't see that ball of calcium protruding in the annulus. And that's what gives you sometimes the core valve regret, because you don't get good coaptation of the valve to the annulus. So I think that that's a reason why I think why a core valve would be you know, the more gentile type of approach, because you're not going to be putting a balloon there in that very calcified annulus. And as Eberhard said, rupture is definitely a risk. But I see this as a favorable anatomy for a core valve because of the lack of a protruding ball of calcium.
Yeah, Pablo?
Well, I agree. I will go with a 34 Evolut, but I will say that with the lack of protrusion of the calcium, also the risk of rupture, I think, is less if you don't have a volumetric amount of calcium protruding into the LVOT.
Yeah. Okay, go ahead.
So going back to the axis, we felt that the only thing that might add a little bit of challenge, but not to the extent to preclude transfemoral axis, is the way those two iliacs wrap around each other. But again, lumen of both vessels were spacious enough to accommodate any sheet. So we decided to go transfemoral. So here we are the day of the procedure. And here we're advancing a 20 French dry seal. We wanted to put a sheet to facilitate exchange catheters in case of need. And as you can see, we had no difficulties advancing the sheet, and the tip of the sheet accommodates inside those grafts without any problem. And once we put the sheet, so we cross the valve, that's the baseline gradient. We check our angles, and here is how our valve is approaching that native aortic valve. And as we go and we're trying to cross, we're pushing really hard on the delivery catheter, but our valve is stuck there. It's just not crossing.
What wire are you using here?
So right now we have an Amplex stiff wire at this point.
No. This is a Confida.
I'm sorry, a Confida wire.
Yes. Okay.
So we're not, so despite significant pull and push, we're not able to cross the valve. And so we're wondering what's happening, and going back to the CT scan analysis, we're not sure if these two curves on the aortic arch are biasing our catheters, are not allowing our catheter to be really centered on the aorta. On the right side, you can see on this cost overlap view that when the capsule is approaching the valve, it's not going really perpendicular to the opening of the valve, but instead the catheter is more biased and the wire is biased towards that posterior wall, the outer curvature. And this is kind of what the same thing that we see here. We see the valve is impinging on that calcium on the non-coronary sinus. And this is the vector force of the catheter when we're pushing, instead of a more center and perpendicular orientation of the valve in that native. So the question is, what do we do at this point? We already did pull and push. Sometimes the wire can get entrapped in the commissure if it's calcified. We didn't pull out the wire out of the ventricle, but we move our wire and we make sure that the wire was in a different location, and we already pushed significantly and we're not able to cross. So I'm not sure if any input of what to do next. I know there's multiple possibilities, but we're cognizant that all these possibilities are at the expense of more aortic manipulation and increased risk of possible complications. So any suggestions on?
I think, well, once you're across, so it's always a pain to recross, to snare, to try. Maybe you can snare from the right wrist, from the right radial, and try to change that angle when you're entering. I will probably valvuloplasty to see if I can facilitate. I think that will be the easiest and fastest way to do this. But if that doesn't work, I would consider snaring from the right so I can change the angle.
Correct, and that was our first approach. So we increased wire stiffness. We changed our wire for a Lunderquist, and we pre-dilated with a 20 millimeter true balloon. And I think we achieved maximal expansion of that balloon there. And then after balloon pre-dilation, this is us trying again. We go with the same valve, and it's the same problem.
So it's an angle problem.
I guess you're very happy with the gore sheet that you started with, right?
Yeah. So Eberhard, any ideas here?
Yeah, I mean, I don't want to be a smart ass, but I think, once you could see, number one, by the calcium and also the way the prosthesis went down, it will go into the non-coronary cusp, and that doesn't change. Even if you pre-dilate, it's an angle. It's a descending aorta will always guide this into the wrong sinus. So I would probably, snaring is, now you have to pull everything back. It's a little bit more complex. That's obviously the safest probably, and the guarantee that you can get through. But I would probably use a body wire. I would have given the CT on the calcification. I would have probably used a Lunderquist from the start. And sometimes when you go back into the descending aorta and turn, sometimes due to the spine of the delivery catheter, you're able to change the descending part and be able to cross. That would be the easiest. But now that you tried the Lunderquist, probably I would use a second Lunderquist in order to maybe get it done. If that doesn't work, then you have to do the body balloon. But remember, the body balloon takes also space in the peripheral and in the stent area. So probably the next step would be a body wire.
Yeah, we actually tried exactly what you said about changing rotating the catheter, so we would change the backbone of the catheter, so it'd see if it would give us more dilation. It didn't help. No. We thought about putting a buddy balloon, or a buddy wire, but I thought that it wasn't going to be able to change our angle, which was still the big problem. So here we thought that perhaps all we needed to do was pull it a little bit, even though if you predict where the snare is going to go, it's going to follow the device. And so it's really hard to turn it more than a little bit when you have this vertical approach. By the way, this is extremely unusual. I have never had a core valve that I couldn't get across a native aortic valve. We've had to do some manipulations for valve and valves, but in a native aortic valve, I haven't had this problem. But anyway, so go ahead, Sergio, let's show what we did.
Eddie,
watch what
last year we had in a live case for the Brazilian Society, we had a case just like that. And we did all attempts, and the way it worked was pulling everything out, snaring in the abdominal aorta, and it did work very well after snaring.
Yeah.
Yeah, but so here we go. That's what we're gonna do.
So,
let's
so,
go.
that's what we did. We got contralateral femoral axis and we snare. And this is the second time we cross after we snare. Of course, we checked the valve integrity, which seemed to be okay after we had taken it out of the body twice. We snare our capsule, and then from then on, we move everything in block, and this is how it bends, and how it bends those tortuosities that we saw on CT scan in the aortic arch.
Yeah.
Can you point out the snare there with your pointer? I don't know if you have that.
Yeah, so at this moment, the snare is at the tip of the capsule, or close to the nose cone. I'm gonna point it out in 1 second as we approach to the valve. I'm gonna highlight it.
Remember, Eddie, the first core valves we snared around the arch.
That's right. That's right.
So once we're closed, the snare is at the mid-level of the capsule, but we're able to advance the snare all the way this cell to the tip of the capsule where it's supposed to be. And right there, we're trying to push on our valve and change the angulation with the snare, pulling on our snare. And we're definitely not successful. Just to point out on the right, that's where our snare is at this moment. So almost at the tip of the capsule, close to the nose cone.
And you can also see that it's a porcelain aorta. So this whole aorta is extremely rigid. You know, you can see the calcification on the outer curve there. And that's one of the major problems we're having here.
Correct.
Do you think you can change the angle better if you would have done it from the arm?
I don't think so, because we're going straight down either way. See, the problem is that when we tug, we're pulling straight back. The only thing I think I could have done, but I was a little hesitant to do, was bring the snare all the way down to the soft portion of the core valve and pull it up.
Yeah.
That's what I would have done.
Yeah.
Go all the way down.
I was a little hesitant to do it because I was afraid that I could get it stuck in the interchange there. And so that's the reason.
Then you can't release it. Yeah.
So anyway,
clearly, as you said, in a not very horizontal aorta, it's a matter of vector forces. So as we're pulling on the snare, what we really want is change the angulation. But what's really happening is we're pulling our valve out instead of changing the angulation. So it clearly didn't work. So at this point, we've been an hour into the case. We crossed the valve twice. We took the valve in and out of the body 3 times. So I'm just gonna give it away. What we decided is go to the active flexion capabilities of a different platform. And yeah.
Did you ever BAV? Did you ever think about that?
Yes,
doing a BAV?
Yes, Dr. Cohen, our first step was increase the stiffness of the wire and do a BAV.
Yeah, you missed that, but we had already done that. Yes.
So at this point in time, we decide to rely on the flex capabilities of the Commander delivery catheter. Just to remind, the flex capability is new of this delivery catheter compared to previous iterations like the Nova Flex, which did not have this capability. So we have the patient under anesthesia, but we're able to get a different platform. And this is us advancing the Commander delivery catheter. And as we're advancing, we're adding more flex and flex to the catheter.
Yeah, this is conscious sedation though, not anesthesia. Yeah.
Sergio, how did you handle the access? Because the Edwards valve comes with the E-sheath.
No, so we put this through the 20 French trisel that we had put in the first place.
Okay.
Yeah. And this is our Edwards valve approaching the valve, and actually was not easy to cross either. We had to add much more flex at this point and manipulate it, rotate a little bit the catheter, but it finally, towards the end of the picture, you see that it jumps in. Yeah, right there. And so once we went in, we're able to deploy our valve because we expected greater shrinkage, and that could pull up the valve. We started a little lower than intended, and we're pushing actively on our valve. but I think that you'll see the final deployment, it's an optimal deployment.
Beautiful.
Yep, very good.
Yeah, I mean, we were also paying attention to that calcium in the anterior, in the left coronary cusp going into the outflow tract and seeing how much that moved. I know that Mauricio had a case where that calcium moved forward and he had to actually put a plug in the ventricle there. So obviously we were paying a lot of attention to that. And we were really concerned about the possibility of rupture, but at this point, we figured that manipulating the aorta with multiple devices was also going to be a potential complication for the patient. And so we went to this.
Very good.
But a
Eddie.
good result.
Very good.
He felt better, and luckily he was able to go back, play golf. This is one of the books he's written recently, and that was a nice result.
Very good. Great. So
Did you use protection? No, huh?
no.
It did not.
We are using protection occasionally. We're not using it that frequently. That's something that I'd kind of like to ask the panel about also. How much are you using protection, Pablo?
I would say like 10% of cases, not just, specific cases, not in general. We're not doing systematically. I don't know. How about you guys?
Oh no, even less than that. We had at first we had trouble with contracting and so forth, and then after that we've only used it in, I would say, 3 or 4 patients. I found it helpful, but I've also thought that I haven't been getting complete protection. How about you, Fabio?
We don't have it in Brazil yet, but my perception is that I would use it a lot if I had it.
Mhm.
Dr. Di Marchena,
Yes.
of course, you mentioned already cases of very horizontal aortas where the pushability becomes difficult because of the angle. We had a very similar case of difficulty to cross with an angle which was not as horizontal. And we found that patients will have either a 0 bicuspid valve or has significant calcification between the right and the non-coronary cusp. The forces that we push against the valve faces the calcium sometimes become an issue. And we were able to solve it by putting a snare technique, but the way that the valve was behaving there was just in the very, very similar. I would like to see, again, if you can show that the morphology, the distribution of calcium. I saw there was calcium distributing the left, but I wonder if there's calcium also between the right and the non-coronary cusp, which is where we faced in the past some difficulty.
There is, I'm going to skip your, not show you that, but I'm going to tell you that there was, because you are almost like a person that's going to be a commentator that says that this guy hasn't hit a home run in a few years, and then the player comes up and hits a home run. That's exactly what, because we're going to case number 2 with Pablo Rengifo Moreno. So Pablo, he stole a little bit of your thunder, but go ahead.
No, that's beautiful. I love it.
Sorry, Pablito. It was totally not intentional, my friend.
Papa, don't worry. It's all good. Let me just share here. Are you guys seeing my screen?
Yes, but very small.
Yeah.
How about now?
It's still a little small. I don't know.
No, we see it now.
It's better.
Is better? Okay.
Yeah.
Well, first of all, thank you. It's good to see the family, at least through here. Has been a while since I graduated in 16, but and now I see all the junior fellows, the general fellows, our structural attendings. Is great. So first of all, I'm in Tallahassee, Florida, and just to explain a little bit my practice, we are the structural practice around 150 miles. So we cover patients from far away from here, and we have to have clinics where our nurse practitioners kind of gather the information before we even see the patient. So we are making sure that patients are properly worked up. With that, the case of a carpenter, a retired carpenter, who comes to our clinic from a 2-hour trip, and he states when he sees our nurse practitioner that he's extremely short of breath. He's having a hard time breathing. He looks pretty bad. in the clinic, and I get a phone call from my nurse practitioner. I was about to leave the hospital and going for the weekend, and she tells me, look, I have this guy. He has an EF of 30%. He had an LV thrombus on Coumadin, triple vessel disease, and very severe aortic stenosis with a valve area of 0.4, approximately 4 months prior in November. Due to COVID, he had gone to a different hospital. Due to COVID, they paused everything and they didn't send the patient to our clinic, which was open through the COVID pandemic anyway. But in this Friday afternoon, I tell her, well, send him to the hospital. I will wait here. I will see him, we'll tune him up, and probably we'll have to add him next week for TAVR. She didn't send him right away. She sent her for a CT scan for TAVR before he hit the hospital. I saw him, he was in severe volume overload, and we decided to start him on diuresis over the weekend. He diuresed approximately 5 liters, I think it was, and started to do better. When they did the echocardiogram the next day, his ejection fraction was 10 to 15%. Severe global hypokinesis with stage 3 diastolic dysfunction. There was already some mild dilated RV with severe hypokinesis. Peak velocity was 4.6 and a mean grade of 55 with a valve area of 0.3 to 0.4. Moderate MR, moderate TR, and severe pulmonary hypertension with mild to moderate pericardial effusion. All bad criteria for surgeons. When my surgeons saw him, they say, no way. He needs TAVR and PCI or BAB and PCI. The other tricky part is that he's a bicuspid. So which becomes already an issue for when you're considering doing BAV as a transition to a transcatheter definite therapy. And one thing we don't like is when we have the right and non-coronary cause fusion, like my professor Joao was telling you guys about. They tend to be more challenging when treating them. This was sized to a 34 Evolut Pro Plus. But at this point, this was the weekend. One of my partners, interventional cardiologist, not structural, was taking care of the patient. I was actually away. I come back on Sunday. I saw that the patient was diuresing well. When I checked from the computer at home, he was on a LASIK strip, negative balance 2.5, but the patient started becoming orthostatic, so this LASIK was stopped. Sunday, cardiovascular surgery considered him extreme high risk and asked for PCI TAVR to be considered. And on early morning, I get a phone call around 2 in the morning. The patient had 2 episodes of hypotension, and now he's on 2 pressors. And I call my partner. My practice, I was recruited by this incredible guy, Tom Knoll. We actually scrub in all the structural cases in my program. It doesn't matter what it is, we scrub together. And we said, dude, we have to do this case tomorrow morning, 7 a.m. We have to be doing this. So we called the surgeon, we put it all together. And we decided that this was a case that was gonna need more than just TAVR, PCI. We needed to make a good plan because things were going south very quickly. So at this point, just to talk about it, we have a patient with the EF of 10%, triple vessel disease. I didn't show you the CAT films because we only have paper reports at this point because we didn't know the patient that well. The films weren't there and we didn't have enough information.
How are you?
So we were thinking, left ventricular support, BAV, PCI, if TAVR, PCI first, if TAVR, BAV, then PCI, then TAVR, general anesthesia, TE, if TAVR, balloon or self-expandable. I don't know what you guys think.
Very good. So normally in these type of patients, we usually would, if we think that the valve is critical, we would do either a supported valvuloplasty or a valvuloplasty and a PCI in the same sitting in order to stabilize the patient for possible TAVR later. Although I know some people will do a TAVR in the same sitting. I don't know about the rest of you. What would you do, Fabio, in this type of case?
Yeah, I'm very impressed with 55 mean gradient in the 10% ejection fraction. So this ventricle still it's still working a lot. And I would treat the valve first. I would do TAVR. And even though we might have difficulties doing the PCI afterwards, I would tackle the valve first and leave the coronaries for a second round.
How about you, Eberhard?
That's really very difficult. My first question, because you only mentioned in the beginning, what is going on with the thrombus?
The thrombus is clear now.
Oh,
We did
okay.
an echo. We did an echo
Okay,
on
okay.
Saturday morning. Yeah.
Okay, so then thrombus is not an issue anymore. Well, I mean, you know, if you have a ventricle with an ejection fraction of 10, you know, there's not much tolerance. Usually, you're happy when you get the valve in and quickly out. That's what we usually do. 10% is really not much. I assume that the ventricle is somehow stunned, and you know, probably it is. He will do better when you do the balloon valvuloplasty. But most probably, I would focus on the TAVR first, and then do an injection once the patient is stabilized, and you can see he's doing better after TAVR. Then I would try to do a coronary angiogram, or you do the angiogram beforehand. And if it's not too complex and you're not adding another risk, then I would do the PCI in the same session. Otherwise, I would defer.
Mauricio, you want to talk a little bit about the Impella assisted?
Yeah, that's exactly what I was. That's exactly what I was thinking. Eddie, you read my mind.
Yeah.
So we've had these cases before. So I think that 10% ejection fraction for TAVR and the rapid pacing and the 3-vessel disease, I think it's a little bit too much. So in these cases, we came up with the idea. So it was Juan Londoño actually who brought the patient for tandem heart when Bill O'Neill was still working with us. And then Bill had this idea of just shoving the Impella through the stenotic aortic valve and do the VAV with the Impella on the side, and that became kind of a new thing. And we published our the first ever series back in 2013 or 2012. I think Claudia Martinez was the first author. So, I mean, that's something that resulted for us. I think 10% ejection fraction is something that you cannot do the two things independent from the other. You have to treat somehow the valve and you have to treat the coronary. So my proposal for this would be to put an Impella first, cross with the two wires, do a valvuloplasty, do the coronaries, let the patient recover for about a couple of weeks, check again because sometimes if they have viable myocardium, the ejection fraction will recover very quickly, and probably bring the patient, once the patient is stable and the symptoms are improved, bring the patient back and do the TAVR. And then it's a completely different patient for the TAVR. It just becomes almost a routine TAVR.
I know that Tony's also done quite a few of these with cardiopulmonary assist when he does these procedures, and they also seem to do very well. Pablo, can you go ahead and continue, because we got 3 or more cases? Yeah.
So to make our decision easier, the patient's systolic blood pressure dropped to the low 50s as he was being transported to the cath lab from the holding area. So remembering Dr. Daher talking to about his Mexican friend, I don't remember his Mexican friend's name, but his Mexican friends was putting everybody on bypass when they had low EF. So I talked to the surgeon.
Quintanilla is the name of it.
Yeah, exactly. So I said, talk to the surgeon, tell him to put the patient on fen-phen bypass. That will help a little bit. It will not unload the ventricle like I want, but it will do some. So we decided to talk to Dr. Ferguson, who is a great surgeon, works with us, and he puts the patient in bypass. And actually the EF improved a little bit on bypass. So our mindset was, how can we do this procedure as fast as possible? I particularly didn't believe that doing a BAV PCI would be the best thing here, because one thing that he probably wouldn't tolerate was AI. And if I do a BAV and he ended up with AI, that would be a major problem for us. And so Tom and I talk and we say, why don't we snare from the get-go? It's a right and non-coronary cost. They're usually challenging to cross. Let's just do whatever is going to be fastest. So we put a multi-purpose catheter. We have done, we were in the bicuspid trial for Medtronic, and we did a few of these, and we found the success when we snare from the left. That will help us a lot. So we snare from the left, from the get-go. We cross under the bypass. This is an edited video. It wasn't that easy to cross that valve. We have a double curve Lunderquist in the ventricle there. And we decided to do a BAV with a 25 size to a 24. And as you can see, we do have significant AI as a result of that. We use the snare. You can see how we straighten the valve to cross it in, putting some tension, and that really facilitated it. This was not edited. This is how it went. It was easy to.
But you're also pushing forward here at the same time.
We're
right?
pushing forward, but
pushing forward.
Yeah, exactly. And so that facilitated crossing so much. When we have a right and nons, we usually just put a snare and we do it like that. It just makes our lives easier. So the next thing, we like our height there and we release, but I don't know if you noticed something that the Marchena always noticed. We had an invagination of the valve, an infolding of the core valve. So I didn't have the floor save, but we decided, what can we do? We really are in a hurry here. We want to do this fast. We tried to release it in the ascending aorta in hopes that it will expand, but as you can see, it doesn't expand. So we had to change valves again. Now we push the neo valve, and you can see that the leaflet is prolapsing into the LVOT. We decided, well, you know what? We're just gonna do this. You can see in the T in the center here how the leaflet is prolapsing, and you have all this chunk of calcium prolapsing into the LVOT. We decided that we have to put this valve in. We start deploying the valve. We have some AI there. That's an 80%, and we like our height, but we didn't like the fact that we had so much AI. So we did 2 balloon inflations with a 28 size to 27. And you are going to see how humbling is this TE. You're seeing the balloon inflating, and on deflation and pulling the balloon out, you're going to see here how that prolapse looks horrible. Very unappealing. So at this point, it is what it is. We don't have much AI, but we have that chunk of calcium. We checked, there was no gradient through the LVOT, which was a miracle. We had to continue. We decided to do everything that we need to do in this procedure. So then we went with a JR4 catheter, whisper wire, and a telescope, which is a kind of like a guideliner from Medtronic. It's very slippery, so it's very easy to push. So it did help, and we got there. We pre-dilated with a 2.5 balloon and put an onyx stent, and we had a good result. Then we went with a JL35 and telescope again with a whisper wire into the LAD. I don't know if you can see there, but the balloon doesn't expand. That's a 2.0 by 20 balloon. We went with a non-compliant 2.5 by 8 at 28 atmospheres. It doesn't expand. At this point, we're like, what do we do now?
So Pablo, this is Mauricio here.
Sure.
I have a question for you. I'm sorry for interrupting, but so if you had the patient on pump, right? You have a
Yeah.
patient on cardiopulmonary bypass.
Yes, but it's fem-fem. It's not really unloading the ventricle.
Okay, so did you think about doing the coronaries first before putting a potential obstacle with the valve?
We did, but the fact with the valve area of 0.3 and everything was happening, we thought the valve was the main problem. And then we did a VAV, and the VAV, we thought doing the VAV and then the PCI. But when the VAV, we had that amount of AI, we thought that the next step.
But do you think that, but you're using a different type, you know, you're actually using an assist device that causes AI. So do you think that the AI could have been, you know, exaggerated because by the fact that you're using a fem-fem?
Not with that chunk, not with that chunk of calcium that will go into the LVOT and out. That prolapsing, we didn't. I mean, that when we saw that calcium going into the LVOT and coming out of the LVOT, we thought that was VAV caused, not because of the bypass.
Okay, and then maybe you mentioned that before. So why did you choose, if you knew that you had to do so much work in the coronaries, why did you choose the core valve as opposed to an Edwards?
Well, the rapid pacing, we didn't want a rapid pace.
But you're on bypass.
We're on fem-fem bypass. That is not unloading my left ventricle.
Okay.
So it didn't, and actually we had already RV dilation. We have done some fem-fem bypass where we see that the RV actually gets a little bit smaller. We didn't see that doing in this case.
You know, that actually probably the perfect support device for this is actually a tandem heart.
Yeah, it will be a tandem. We don't have it available in our institution, but
Yeah.
tandem heart
I
will
mean,
give you that. Will
I
give
think
you
that Eberhard did his first couple of core valves with the tandem heart. Is that correct,
Right.
Eberhard?
Yeah, right.
Because it made so much sense physiologically as a way to support. It's out of your way in the aorta, and it's unloading your ventricle. At the same time, you're getting oxygenation. Now with the new tandem hearts, we could even do more.
Yeah,
Anyway.
we don't have it, so that will be the ideal support device, but we didn't have it.
Yeah. Okay. So go ahead. I'm sorry. We have to pick it up a little bit before we can get to the other cases.
Okay, so we did shockwave of the LAD. And just to let you know, shockwave, you have to do 50-50 contrast. If you don't do 50-50 contrast, you cannot see the balloon well. We put a 3.0, what's happening? A 3.0/26 resolute onyx, and this is the final result here.
Beautiful.
So for some reason,
A shockwave you've just had for a little while, right? For coronary shockwave.
this was my second or third case of shockwave. But
Very nice.
But they had approved it like a week prior, so I was like, okay, well, let's do shockwave. That worked once, it should work, and it works beautifully.
Yeah, it was
I have
just
to say.
approved in the United States. We don't have it yet in the
Yeah,
coronary.
Yeah, that had approved like a week prior. So this is the on post day 3. We have to do some bronchoscopies, and the patient recovered actually quite well. On post day of day 4, he was ambulating for the first time. You can see the EF. It was called 40 to 45% by a non-invasive cardiologist, not by me. I think it looks beautiful. He does have some AI, but he's tolerating quite well. And he went home 7 days after home. So the mean gradient through the valve is 9 or 8 millimeters of mercury. And he has mild AI by echocardiogram. It looks a little ugly. I think it's in relationship with that chunk of calcium. The LVOT is not obstructed, but that's something we have to follow. I don't know how that's going to behave in the future.
Yeah, you really saved this guy's life. I'll tell you that, because the Grim Reaper was really pulling on his leg there.
And in some ways, I have to say that, let me stop video here, stop sharing.
On the top.
On the top. I don't know, does somebody does it or I do it?
No, you can do it. Stop sharing your
Okay,
screen.
there you go. I
There
found
you
it.
go.
Okay. So I think in a way, we didn't have the right answers or the wrong answers. We just have to react very quickly because the guy, I mean, we thought we had time and he was just going down the tubes around 3 in the morning. By 8:30, he was fixed.
You can see, I want Eberhard to notice that Paolo is trained in interventional and in structural at University of Miami. So look at the type of skills that this guy can pull off. It's
Yeah, you could tell. He got through the, he did everything on this patient.
Yeah, I mean,
Yeah,
I'm very impressed.
it was very challenging, but we were lucky. I mean, we didn't want to do CSI. We didn't know the pictures that we get sometimes is challenging because when you're working in a place that serves underserved areas, you really don't know what you're getting and the information you're getting.
Beautiful.
Yeah.
Very good. So let's go on to Joao's case. Joao?
All right, let me unmute here. I never got a chance to say hello to Dr. Cohen, to Dr. Alfonso, to Dr. Gagger. It's very nice to be here with you guys. Let me share my screen here. Are you able to see it or no?
Yes, but we don't have it. There you go.
Perfect. Again, Dr. De Marchena, thank you so much. Pablito, what a great case. You're an outstanding structuralist interventional cardiologist, just was superb. I'm presenting the third case. I have no financial disclosures. The disclosure I want to make is I did this case with Dr. Cesar Mendoza, and we pre-planned with Dr. Ferreira, Camilo, Gomez, and Bashar, and they are a fantastic team to work with. It's a really feels like a blessing to work with this team. I'm presenting a case of a 76-year-old. She's originally from Nicaragua. She's a retired school teacher. She's been living in the United States for the past 20 years. As you can see her, she has quite a few comorbidities. She's known to have a decreased ejection fraction from non-ischemic cardiomyopathy with ejection fraction from 25 to 30%. She has diabetes, hypertension, frailty, and CKD. Okay, can you see now better? I'm sorry, some technical issues. Dr. Perez was able to fix it. I skipped her echo, but she also has something to say. She had a previous BAV in 2017 when she was evaluated at a previous outside medical facility, as she was considered to have a high risk for both SAVR and TAVR. I'm sorry, I couldn't hear you. Did somebody make a comment?
No, go ahead.
So again, it's an important piece of information that I need to say. She was previously evaluated in another facility in 2017. At the time, she was already known to have a decreased ejection fraction and to have severe aortic stenosis. She had a valvuloplasty instead of a TAVR because she was considered to be at high risk for TAVR, and we're going to soon find why. Given the background of diabetes, pulmonary hypertension, moderate to severe mitral regurgitation, frailty, and she's a Jehovah's Witness, she was also considered to be also a very high risk for surgery. This is her echocardiogram. Her ejection fraction was diminished 25 to 30%. For some reason, it's not playing. I'm going to play again. And she had also moderate to severe mitral regurgitation. She had pulmonary hypertension with the pulmonary pressures estimated at 50 to 60, and severe aortic stenosis. Dr. Brito made a comment very early in the previous case with a low EF. The patient was able to generate high pressures. Despite having a low EF, this lady was also able to generate high pressures. Her velocity was 455 with a mean gradient of 48. This is her coronary angiogram. She had non-ischemic cardiomyopathy, probably from multivalvular disease. We can also see the fluoroscopy, how much calcium she had in the aortic annulus, and a dominant right coronary, which all coronaries had no significant obstructive coronary disease. This is her CT, and she had significant calcification at the level of the non-coronary cusp, which was extending to the LVOT. Her area was measured at 396, which is sizer for a 23 valve, and the perimeter was 78.1, which actually is sizer between a 26 and 29 self-expanding valve. her sinuses were not that large, particularly the left sinus measured 27.6 millimeters. For 29 self-expanding valve would certainly be too small. For 26 would be also a challenging valve or challenging for potential coronary obstruction, particularly looking at the left coronary height of 6.4, as we can see here. The right coronary was height was 11.1. So the first question that I would like to ask, and I think we discussed a little bit about calcium extending to the LVOT, would be which valve platform would you choose, and what size, or we should reconsider possibility of surgery. Of course, this is I don't think we have any surgeons in our panel, or should we do a sizing BAV as trying to figure out which valve would fit best for this patient.
Okay, I mean, I think that you saw that extensive calcium. I think most people would try to go with a self-expanding valve if they can. But can you go ahead and go, because I think the other points that you're making are so important in this case.
Beautiful. So we ahead of the time, because of that extending calcium in the LVOT, we thought that a self-expanding valve would be a better option. And we're of course concerned with the oversizing, particularly with that left sinus of 27 and the low coronary height. We were concerned with the NFA sinus and occlusion of the coronary. The second question for the panel is, how would you approach the left coronary, which had a height of 6.4, or would go ahead and deploy the valve and take our chances of no coronary protection, do coronary protection, do a BAV angiography, or consider a basilica of a native leaflet. Anybody would like to make any comments?
So Fabio.
Yeah, I would protect the coronary for sure in this case.
And how would you protect it?
I would put a wire and a stent there inside and leave it there. Just after deploying the valve, we decide if we have to leave the stent in.
I agree with the protection. I would add a guide liner in case I don't need the stent. I pull that stent through the guide liner so it doesn't avoid any interaction with the metallic valve.
So yes, we're in the same line. We thought because of the low coronary, the narrow sinus, coronary protection would be important here. One thing to make an important point, and
By the way, it's one last point on that is that if you look at your coronary is coming off really at the raphe of the valve. And so a basilica, I don't think would be helpful to you because this is that coronary that's taking off almost at 6 o'clock.
That's the home run that you made. That's the home run you were referring before. I was right about to say that.
Okay.
But we'll review. I won't waste time with femoral anatomy. There was a concern with the dissection, but the vessels, we thought it was hard enough, the vessels were large enough for transfemoral access. So we used the right femoral as our large bore access. We used the left femoral for coronary protection. We got a pigtail from the right radial. And this patient had already an AICD, so we just used a magnet and decided to temporarily paste from the left side. Anticipating the need for deploying a stent, as Dr. Brito mentioned, we decided to IVUS the perfectly sized our left main, and our vessel reference was 4.5. So we had a wire in the coronary, used the Sheehan blue for IVUS, and then once we had did balloon valvuloplasty, we had a supported wire with a Grand Slam. Now, something to mention here is we decided to do a BAV with coronary protection and look at the position of the pigtail. The pigtail is not sitting at the cusp like we usually do for annulus angiography, but high above the balloon, and we can see there's almost no flow on the left coronary system once the balloon is inflated, which may even more impact on our decision of having a stent there. So what we have here is, again, coronary protection. We had our reference size stent 4.5 by 22 onyx with a telescope as our guide extension. We don't carry guide liners here anymore, Felipe. This is our guide liner now. And once we have our stent sitting there, we we had another question is how are we going to approach coronary alignment, given that coronary coming out of the RAFE, and I'll show you exactly what I mean. We have the paper from Grube Tank describing the Align TAVR trial, demonstrating that particularly when you're using a self-explaining platform from Medtronic and Evolut, if you have your outer curve a head marker, you have at least one of the coronary neosinuses aligned with the coronary intake in about 73.6% of the cases, which became our standard of care when we're doing self-expanding valves here to rotate our deployment delivery system at 90 degrees at 3 o'clock to try to reestablish the coronary, the neosinuses with the outtake of the coronaries, assuming that you had a 120 degrees angle between the right and the left coronary. Now, looking at the design of the Evolut valve and going a little bit deeper on that process of coronary alignment, we have the C-tab, which is this shown here in green, where is attached to a hinge point. You have a non-C-tab, which is actually located in the middle of a neosinuses. So they are not necessarily in relationship to the valve sinuses represents the same location and same placement of neosinuses. When we thought about doing coronary alignment on this particular case, we believed that because of the anatomy of the patient having a left coronary coming in the hinge point, we would have the new valve sitting right at that location. So if we thought about deploying the valve at 3 o'clock, the hinge point of the Evolut valve was sitting right at that coronary, which was not favorable for us. Then we thought, what about if we don't deploy the valve at 3 o'clock and we just use the standard mechanism that we used to do before? Well, that would be a possibility. Nevertheless, the heart marker wouldn't be in the outer curvature, and therefore we wouldn't be certainty of where are we deploying the neosinuses. So we try to come up with new ideas. What if we invert the valve loading? What do I mean by this? When we're preparing the C-tab or we're preparing the valve, we aligned the C-tab as we mounting the valve. Our idea was, what if we, instead of loading the C-tab, we load the non-C-tab? In other words, we're rotating the valve 180 degrees. By doing this, we wouldn't do any better because the hinge point of the valve would be one more time facing the outtake of the left coronary. But if we aligned the valve upside down and rotate at 30 degrees, we will be able to align the outtake of the left coronary cusp, which was our major concerns, with the neosinuses, and we would be able to track the heart mark and the outer curvature. So going revision again, all the strategies. If we deploy the valve at 3 o'clock, we'll have some alignment of the left coronary cusp, but we will not be able to track the outer curvature head marker. If we rotate it at 3 o'clock, like we normally do in the most of our cases, we will be able to track the head mark and the outer curvature, but we will not be able to align the coronary with the neosinuses. If we deployed at 3 o'clock without any rotation, we would not accomplish none of those. We wouldn't have alignment of the coronary, neither able to track the head marker. But if we loaded the valve upside down and rotated at 3 o'clock, we'll be able to track the head marker and the outer curvature. So that's how we decided to approach. So this is our head marker and the outer curvature. We have our stent sitting on a guideline of protecting the coronary. We cross the valve, and we use the overlap technique as we all been doing. Once we have the valve deployed at 80 degrees, we decided to position our stent and deploy it, prolapsing, possibly a little bit outer in the left main, but using this Norco technique. So the stent was deployed and the valve was slowly released. And once the valve slowly released, we post-dilated the stent with a 5-hole non-compliant balloon. This is the gradient showing significant improvement of the aortic stenosis. And then once we did post dilation, we decided to IVUS. And we can see here on the right side, we have some struts prolapsing in the neocusp and full expansion of the stent into the left main. This is our final angiogram, and we're saying goodbye probably forever to the left coronary and retrieving the wire. Would be very hard to get it back with the prolapsing stent into the neocusp. This is the post-TAVR echocardiogram. We can see that the ejection fraction already started to recover. The gradient across the valve was very similar to what we got with invasive hemodynamics. And this moderate to severe mitral regurgitation significantly improved now to mild. And there was already markedly improved in the pulmonary hypertension when it was 50 to 70 before and now down to 28.9. This is the pre and post echocardiogram. We can see that the ventricle was much happier than before after we relieved that significant aortic stenosis. And then we did a CT to compare what we planned and what we achieved. And we can see here in the yellow is the non-CTAB, and in green is the CTAB compared to the projection of our valve. And we can see that particularly the non-CTAB was very well positioned compared to what we pre-planned. And I guess because of some possibly some compression or the distortion, a little bit of distortion of the valve, we would not totally align with the Commissure tab. But that was very satisfactory to what we planned. When we look at the CT reconstruction, we can also see that the overlap between the valve, what we planned with the neo valve, and the native coronary anatomy, we're able to accomplish as what we plan as reconstructing the neo sinus of the valve. So in conclusion here, I mean, they're all patients that are, we all know very well the patients who are high risk for SAVR, and we're facing now a lot of, with knowledge that we have a lot of patients, we know it is also high risk for TAVRs, particularly with low coronaries or high calcification in the annulus. And then we're trying to become more creative with innovation and trying to optimize our procedures. And this is, I'm not sure if we made major impact, given that we're never going to go back to the left coronary. And we have already a stent there, but the idea of thinking on possible ways that we can optimize our procedure, trying to decrease shear flow on those coronaries. This is something that we always have to be aiming and pursuing for optimal techniques. I have also to thank the team from Medtronic. We're very blessed of having a wonderful support from our technical specialist. Luis Acevedo is a fabulous, give us fabulous support, and in particular in this case. And we wouldn't be able to come with this whole plan if it wasn't for his expertise.
Very good. That was really interesting thinking. Eberhard, any comments on that?
No, I think that was a beautiful example on how things, what we have learned, and how you can think, knowing now the landmarks of the valve and how you can accommodate for the future TAVR issues that we have, by running a way that's completely different from our previous thinking. What John said was really innovation in terms of not only delivery, but also planning the case in view of a very, very difficult situation with low coronaries and no sinuses. Beautifully done. Very well done.
Yeah, I think it would be very interesting to see the same technique when you come across a coronary that has that same type of orientation, but does not need to be protected. Because really the reason we do most of these manipulations is for you have access to your coronary in the future. But I think it really explains well, I think, the whole alignment trial and the whole concepts behind alignment, which are so important.
This is a very, Joao, that was a great case, right thinking. And just to remember that when you look at the echocardiogram sizes of the leaflets, the cusp, that's important too, because they're always the ones that close the coronaries. They are the ones that occlude the coronary.
Yeah.
Very good. Carlos, any comments?
Yeah, no, I congratulate you, Joao, and the team. I mean, it was a great case, of protecting the coronaries. I mean, I kind of was thinking, she's 75 too, and I know you went through the question of why use a self-expanding versus a balloon expandable. I would hate to have to come back, in a couple of years to go into those native coronaries. I mean, there's not many great options there, but I mean, I was thinking whether even a balloon expandable may be an option there for that reason.
Yeah.
But I mean, I think it's a great case how you went through it. So
very good. So that was a beautiful case, and now we move on to Fabio De Brito, who's going to be showing us a really interesting problem here.
We'll try to. So yeah, I think you have my slides now. So Eddie, thank you again for the invitation for this wonderful meeting. I miss all my friends, and hopefully next year we'll be all in Miami. So, yeah, and today I brought what I think it's an interesting and challenging valve-in-valve TAVR case. So this is a 72-year-old woman, New York, heart failure class 3, medical history of aortic valve replacement in 2014 using a Brazilian Braille valve number 21, size 21. She has chronic kidney disease, epilepsy, and the ECG, so sinus rhythm with left ventricular hypertrophy and normal coronary arteries. The echocardiogram shows big left atrium of 61, LV dimensions of 61/42, ejection fraction of 58, and the aortic bioprosthesis with thickened leaflets with a tear in one leaflet resulting in severe aortic regurg. Gradients, aortic valve gradients of 35/19, 19 is the mean gradient, and pulmonary pressure of 56. So the STS predicted risk of mortality was 9, so consider a high risk for surgery. And based on all information we have already showing that valve-in-valve TAVR usually shows better outcomes than native valve TAVR with regard to mortality, stroke, and hospitalization. We considered, of course, this case for a valve-in-valve TAVR. So we went on and did a CT for planning. And this is a Braille valve, as I said, 21, with an internal diameter of 16.7 by CT. And it's about the same as what the manufacturer shows. It's 16 internal diameter with a 2.2 squared centimeters area inside area. So it's a very small valve.
And the Braille has the leaflets mounted on the outside of the frame, right? So it's one of those valves that has a great capacity to occlude coronaries, correct?
Actually, this one is inside, is mounted inside, but it's still a small valve, and it's a little bit tall. It's 11 millimeters in height, so it's a valve with a high risk of coronary occlusion. So this is, as I showed, a small internal diameter. We were concerned about patient prosthesis mismatch. And also, you can see here the CT. You see that the left coronary artery takeoff is very low. It's 1.2, 1.3 millimeters. And the right is at the half of the right coronary ostium is 7. This is the VTC, the valve to coronary was less than 1 for the left coronary artery, and it was a little bit more than 4 for the right coronary artery. And as you know, there's this publication from the European Heart Journal in a few years ago, showing that the VTC of less than 4 and low coronary ostium takeoff is a strong, very strong predictor of coronary occlusion. So we had 2 concerns. One, of course, mismatch, PPM, because of the small internal diameter of the valve. And of course, the second concern is the high risk for left main occlusion. So I would, my questions here, would you consider a valve-in-valve tower for this patient? And if you do, which device and strategy?
How old was the patient, Fabio?
Sorry?
How old was the patient? 72?
72.
Size of the prosthesis is 23 or 25, Fabio?
It's a 21 Braille.
21.
21 Braille with an internal diameter of 16. And this valve cannot be fractured. It's a valve that you cannot fracture.
Yeah, that's the one thing you definitely don't want to do in this case anyway.
No, no.
Yeah,
sure.
so,
Yeah.
you know, remember that in the United States, we have a choice of 2 valve types. And so I'd like you to go ahead and explain why you chose what you did.
Okay, so because of the patient prosthesis mismatch, we decided to use an accurate small. It's an off-label indication because it's a self-expandable supraannular design to improve hemodynamics, but could be the 23 Evolute valve as well. But because of the risk of left main occlusion, we decided to use the accurate valve because we have a more precise technique for commissure alignment that I'm going to show you. We decided to do left coronary artery protection with a stent. We have no experience with basilica, could be used here, but a very complex case is not a situation to start an experience, in my opinion. And we placed the cannulas for ECMO, just leave it there because we could need it. So there's a specific point that I would like to make here for a valve-in-valve implantation for the accurate valve. This is a nice publication in 2019. These pictures here show very nicely that if the upper crown of the valve stays below the posts of the surgical valve, there is a huge underexpansion of the accurate valve. You can see here in this picture shows very well. If the upper crown is below the posts, see that the leaflets are underexpanded. So we have to put the upper crown above the posts of the surgical valve. This is something very important if you consider a valve-in-valve procedure with the accurate valve. Also, we wanted to have commissure alignment, and the technique, we've done 20 cases so far, and we've done CT afterward to confirm, and it worked in every single case. We use CT with right and non-coronary cusp overlap to select the angiographic projection. I illustrated here the non and the right coronary artery with overlap. Then you have the left coronary artery, and we noticed that there is a free cell of the upper crown of the accurate valve that is exactly where the post of the valve is positioned. So we have to turn the valve just that this free cell is not in front of the left coronary artery. As you can see in the left hand side picture, you can see that the upper crown free cell is here, and if you turn the valve, it gets away from the left coronary artery. So we did that. As I mentioned, we protected with a stent there. You can see here the severe aortic regurg, the cannulas of the ECMO positioned, a very, very small ring of the surgical valve. No, I don't know why. Sorry. So we introduced the device and made sure that the free cell was not in front of the left coronary artery, as I showed.
So Fabio, when you do that non-coronary to right coronary alignment, which is the opposite of what we do for the core valve, right?
Yeah.
What angles are you, what angle are you projecting here? Do you have any idea? It looks almost like AP on this one, but yeah.
It's left cranial, always left cranial.
Really interesting.
LAO cranial, yeah. So this is the positioning of the valve, the accurate valve. We made sure by TE that the upper crown was above the posts. As I showed it, this is very important. The valve was deployed. There was no compromise of the left coronary artery. This is the final.
So you think that that alignment prevented more prolapse of the leaflet into the left coronary cusp, right?
Yeah, I think so, but we were really impressed after deploying the valve that there was more space than we thought between the valve and the left coronary artery. So I think
So Fabio, do you really need commissure alignment with the actuate, or you only need it in the valve and valve situation? Because you have larger cells, and I can see the commissure alignment if you have to deploy the valve fairly high, but if you deploy it normally in a normal fashion, not in a valve and valve, do you really care about commissure alignment, or do you have to?
If the coronary artery, if the takeoff of the coronary artery is low, I think it helps a lot with commissure alignment.
But you would get through the cells, right?
Yeah, but it's sometimes we have a hard time getting through the cells to get to the coronary. So
I see.
I think this technique helps a lot to get into the coronary arteries.
Very nice.
Beautiful. What was the gradient after your valve?
Yep. So let's see here. This is ejection fraction was 60. The mean gradient was 16, and the patient was discharged 2 days after the procedure on clopidogrel.
Wonderful.
That's
beautiful
it.
case.
Very nice.
Any comments, Eberhard, on the accurate as you see it as going forward?
No, I don't, we don't use actuate as much, and we certainly don't use it in valve situation. I know Sao Paulo uses it a lot, and I was very, very interested in, the Commissure Alignment that you have to do for actuate. I thought that you don't really need it, but I guess I don't have enough experience with the valve.
Wonderful. Very good. So let's go to our last case. So we're
Very
back
nice,
to,
Fabinho.
we're back to Sergio. Sergio started us off and he's finishing us off here.
Yeah, this one should be a quick case. And I wanted to thank Dr. Daher, who is connected here. I wouldn't be here in part because of if it wasn't for him. So thank you, Dr. Daher. And I wanted to thank Dr. Cohen, the primary cardiologist for this patient, for letting me be involved in the care of this patient. So no disclosures. 65-year-old man with history of coronary disease. He had a first CABG in 2001 with a lima to the LAD, and 9 years later, he had a redo surgery with a redo CABG, a couple more vein graft to the right coronary and the circumflex, and he had a valve replacement for AS, for calcific AS at that time, with a small valve, a 21 millimeter Edwards Magna is 3000. He's a fairly sized patient, but BSA around 1.9. His physical exam and echocardiography was concerning for degeneration of that valve, mainly with restenosis, and that's his EKG. So yeah, with echocardiography, we confirmed that prosthetic valve was significantly stenotic with an EOA of around 0.76. He also had preserved ejection fraction. These are his coronaries. You see on the left his right coronary artery, which has diffuse disease. He had previous stents on the circumflex, which were patent, totally occluded LAD. The vein graft to the right and the vein graft to that circumflex that is open with the stents were occluded, but the lima to the LAD, it's open. So in reality, the only territory probably not fully revascularized was the right coronary artery. But we felt it was okay to proceed for surgical valve replacement. Because of to expedite time, in the setting of a small surgical valve, we went with a supraannular design to achieve the largest EOA possible. So we decided to go with a self-expandable, and in terms of sizing, that 21 millimeter Magna Ace has an internal diameter of 20 millimeter, which we confirmed with CT, and that would be a 23 millimeter Evolut Pro for valve in valve. There was no, conversely to the previous case, there was no concerns for coronary occlusion. The valve to coronary distance was more than 5 millimeters, and despite a low takeoff of around 7 millimeters. The same thing applies for the right coronary. There was plenty of space between the transcatheter valve and those coronaries. And this is a reconstruction just to illustrate. There's not really much calcium in the aorta, except for this area in the arch, but there's not really a lot of significant calcium in the leaflets of the bioprosthetic valve. So I guess the only point of debate here is in the setting of small surgical annuli, do we just put a valve or do we routinely frac this surgical valve? And if we do we do before or after transcatheter valve implantation?
So Tony, you've been fracking now before you do the valve, correct? Dr. Dagger?
He's gone to bed.
No, he's there, but he's muted. You're muted, Tony.
Okay, right now?
Yes, you're fine.
I'm fine now. Okay. No, it's been a long day, but not that. As a matter of fact, great talking to you guys.
Okay, but do you frac before or after you put in the valve?
Before, to answer before, just before.
Yeah,
I think is that I like to look the behavior of the coronaries during the balloon valvuloplasty. That's the major point, okay? That's the advantage of doing pre-valvuloplasty balloon.
No, but I'm saying for fracking an aortic valve, for fracking an aortic valve.
Yes.
Okay, so go ahead, Sergio.
Yeah, so here we are the day of the procedure. We cross the valve, you see the gradient, and we are advancing our delivery catheter. And as So we're positioning our catheter inside the surgical valve. And on the left, you see the deployment. So we're flaring our valve. Makes contact at that depth, and then we continue with the rest of the deployment. And on the right, you see a still frame with the final depth of the deployment at this time. We had actually planned to frac, we had planned to frac the valve after our transcatheter valve. And I guess at this time, we're probably like around 2 millimeters on the side and maybe 4 or 5 millimeters on this, on the left side. So we went ahead and we fracked our valve.
Using up my time here. So I have like 4 minutes and 4.
We know that based on some bench testing, this valve fracks around 18 atmospheres. And just to go one more time, we, in order to achieve full pressure, we usually do a hand inflation, and then we add some more pressure with an insufflator. And here it's us with a 22 millimeter true balloon. And towards the end of this video, you see that the sealing ring fracks around 21 atmospheres right there. I think you can see the exact moment where it fracks. But I want to compare this to the depth of the implant right before fracking and kind of move a little bit. And we're really shallow. We're almost zero on this side of the valve.
Well, that's great. That's really great.
Yeah, and this is the final result of the deployment with good gradients, and I think it's a great result. We're really shallow. There was no conduction abnormalities, and the patient actually did very well. With echocardiogram, we would confirm a very good EOA and minimal gradients on the transcatheter valve. The only thing is that he went home, and his wife called us 72 hours later and saying that he's just not behaving as usual. He just had like strange mood changes. So we brought him in for brain imaging, and unfortunately he had this.
Yeah.
So
he had a lobectomy. He had a frontal lobectomy.
I guess the other point of discussion, and I don't know, I couldn't find any data, but is there any risk of a stroke when we frac this surgical valve and we're doing valve-in-valve procedures? Is there any role of embolic protection devices in this type of cases?
So Sergio, this is a very interesting case. And I have, if I may, have a few comments. Number one, if I recall, the patient is 62 years old. Was that correct?
That's correct.
Most probably, I would have not taken an Evolute. I would have taken the Sapien and post-dilate. I don't like pre-crack. I would do it the way you did it, except I would have probably used a Sapien 23 and crack it afterwards. But we know that valve-in-valve procedures are at increased risk of stroke. So the two indications that I think, at least for the general, application, the bicuspid valves, heavily calcified valves, and valve-in-valve procedures are the one indications that probably we should be using embolic protection. Unfortunately, this patient did have it. That goes along with the recommendation. There are no data yet, but I think if those patients are at higher risk of stroke, the three that I mentioned, and unfortunately he had one. The thing why I was...
No, I just wanted to make a point there before you leave that. Unfortunately, because of the COVID era, a family doesn't visit a patient in the hospital, which is a major problem. But the behavioral changes weren't noted till 48 hours later. One of the things we never know, and that's one of the problems with the embolic protection data, is when do these strokes really occur? That one looks pretty substantial. So I think that it was probably a big piece of something. So it's very likely that it occurred there. And I agree with you that intrinsically it makes sense that valves should have more strokes. But is there data to support that?
No, not yet. But it's a general recommendation that we have those three that I mentioned. The reason, Eddie, why I was thinking of a sapien, possibly the patient might need another valve, and then, you know, and because he's not at risk for coronary obstruction, supraannular in this particular case, when you plan the cracking, it's not really very important because you can increase the effective opening area by cracking the valve, and you have more options in case she should have a third valve. That's why maybe a sapien would be an option.
Yeah, although this was a 21 millimeter valve,
Yeah.
right?
Yeah, yeah.
Correct.
Yeah, so I mean, when you do FRAC, Eberhard, how much do you increase the effective orifice area? Has that been worked out well?
Yes, usually yes, and that's why I would not be so much concerned. If you don't crack, then I agree with you. Then we should use the ones with a better opening area. But if you plan to crack, particularly with small surgical valves, you know, in a younger patients, I would use sapien. In older patients, where chances that you need a third valve is very low, then I would use an Evolute.
Got it. Beautiful.
Dr. D and Dr. Grube, we have a question from the audience I think is pertinent at this point in time.
Yes.
One part of the question was actually the type of valve that you would use, and I think you expanded on that.
Yes.
The other part is what kind of embolic protection devices would you use in this case?
Mhm.
Are you asking me?
Yes, sir.
Well, I would use the one that's approved and that works, and that's the Claret. I don't think that the other one is. We don't have the other one. No, the other one is CE marked actually,
Yes.
but very, very, very rarely used. And we know, we look at the data, it is not that you know effective in protecting. So I would use a Claret.
Yeah, Sentinel here in the United States. Yeah.
Yeah, Sentinel. I mean, sorry.
Yes.
Thank you very much.
Beautiful. Any other question, Hector?
No, Dr. D, not at this time.
I think the other
Thank you.
point,
I think-
point to bring it is, and Sergio, I'm not sure if you told us that, but what was the residual gradient after the valve deployment and before the fracking?
No, so we plan up front to frac the valve. We did not measure gradients in between the transcatheter valve and the fracking. We measure gradients after we had deployed the valve and fracked it.
Nice result though.
Yeah,
Beautiful.
beautiful result.
Very good. So it's been a fantastic evening. I'm going to go ahead and share my Zoom a second, if you could let me. So we're here. So I just want to make a point to first of all, I want to thank Dr. Grube, and you can see why we wanted him to lead off our panel here, his incredible judgment and his, what I always talk about is impeccable honesty. One of the things I love about Dr. Grube is that he will tell you what he thinks, you know, and that's exactly what we need for pioneers. We need people that will be totally honest in their opinions. So I just want to let you know that we have 3 more structural meetings Wednesday night on the 21st, the 28th, and the 25th. On the May 12th, there'll be a PCI symposium that Dr. Cohen and Dr. Alfonso are leading. In May 19th, an EP symposium with Dr. Mitrani. In May 26th, a heart failure symposium with Dr. Grasset and Dr. Gossisab. And then on Saturday, there'll be a 22nd, there'll be a symposium, which will be several hours on heart, lung, and heart transplant, which you can also join. And so we want to make sure you do this. Next week's is going to be another wonderful thought leader in structural heart disease and a dear friend, William O'Neill, who will be doing a potpourri of new therapies in structural cardiology. and with a particular emphasis on new left atrial adventures, which we always know, knowing Bill, that's going to be extremely interesting. Also joining us that day will be Dr. Dagger and Dr. Palacios, as well as our faculty and former fellows. In 2021, by the end of 2021, the masks are coming off. Okay, with one way or another, we're going to get these damn masks off. And in February 3rd to 5th of 2022, we will be back at the Marriott, Miami Marriott Biscayne Bay Hotel for Miami Bows as usual. And I can assure you that we will have Dr. Grube there and all of our wonderful panelists there to help us understand this. So thank you all very much.
Eddie, make sure that you have a hotline to the good Lord that he leaves the hurricanes out, huh?
Yeah, well, that's what we're doing in February. If the hurricanes come, then there's been major climate change.
Eddie, don't take the mask quickly, okay? Because we all remember comments by being locked down.
That's true. Very good.
Well,
thank you all and good night.
Thank you very much.
Have a good night.
Thank you. Bye-bye, Sergio. Bye-bye.
Bye, Emma.